So now we are going to, we've covered the head and the body and kind of focusing on the heart of it all. Okay. Sorry. So I would like to welcome Dr. Patrick Regola from the University of Toronto. Thank you very much for coming.
Right. Thank you very much. I must confess, on the morning session when I realized, thank you, that the vast majority in the audience is physicists, I kind of had a strange feeling. And I must say that I felt like I'm in a very difficult situation here with all the knowledge and intelligence around. But let's see over time, how it develops. So I might change it. My special thanks certainly go to people who contributed to the talk, and here are my disclosures. I'm not paid by any company, in particular not pertaining to the topic I'm talking about. Well, it is not in the United States phenomenon that people die from cardiac events, and I have put up some slides here, some graphs. In fact, this is from Italy showing that the same thing, that one-third, well, it just worked here a minute ago, that one-third of the cardiac events actually are fatal. And if diagnostic imaging picks up the topic, you can be sure it's going to be important, right? And cardiac CT was for a long time regarded as the climax in CT technology, because not only do we need all the features of dose modulation and high contrast and spatial resolution, we also need high time resolution. And that is actually quite critical in cardiac CT. Well, and these situations, this is actually an example. I like to start with this because it illustrates the importance of what can happen in a hospital. This actually is the wife of a head of department from cardiology. Well, cardiologists sometimes have special characters, I must say. So he came to me after he has read the studies and said, you know what, I potentially could do a catheter study for my wife, but I read cardiac CT is actually more accurate. So why don't you do this study? So, well, he was a big shot, so I was obliged to scan the patient myself, which probably brought my adrenaline level a little higher than mine is at the moment. So I was sitting behind the scanner console and trying to scan the patient. First of all, the patient was absolutely the wrong indication because you see here's a lot of calcifications. Number 2, frequency was way too high, refused to take beta blockers. Number 3, didn't follow the breathing commands. I mean, you know the situations that happen in those conditions. So we scanned the patient. Here's the result. In fact, what you see is there's decent image quality, lots of calcifications. The patient was 75 years old, not the right target for us to be scanned. And the only thing is he paid private. He paid cash, right? Another incentive to do it. Anyway, so I found a little lesion here, and you can see yourself. It is, I would say, significant. Maybe not occlusive, but there's a soft plaque, which I think potentially should be treated. Well, the cardiologist, the head of the department, agreed, and naturally what I expected, he performed a CT angiogram, conventional angiogram, next day. Well, I'm not really very experienced in looking at these things, but I would say it doesn't look that bad at all. Now, I cannot repeat what he then said on the phone to me. He came actually back, and the good thing was I was just doing a procedure, so it was nicely covered. That saved actually a couple of the things what he would like to try to do to me. But anyway, I sat down with him at the console and explained what the difference is. The difference is a difference in modality. In fact, conventional angiography shows you only the lumen from one perspective. Well, there's some tricks to change that. But CT actually is more accurate because we have cross-sectional imaging capabilities. And if a plaque is eccentric, you may or not see it only in one projection, which in fact is the truth here. You see it on this cut, but you don't see it on the perpendicular one. And that actually shows you how capable CT is when we have all the things, highest temporal resolution, high spatial resolution, and make use of the latest technology provided by workstations. So sometimes the point here is radiation is indicated for some difficult personalities. Well, don't take that as a take-home point, but there is general agreement among everybody, cardiologists and radiologists. There's only a certain group for which cardiac CT is indicated. Well, if you have a low probability and you do not smoke at all or just a little, there's nothing one should do because the risk is low. The best thing is change your lifestyle. If you have high increase of risk factors, well, you better get a catheter study right away because there's a high chance that you need intervention. So the target group for CT is the medium increase in risk. And there are multiple ways to assess this. And actually, appropriateness criteria put forward actually show the same thing. What the people have said is there's only one indication which is intermediate pretest probability of coronary artery disease, or in certain circumstances, if the EKG is uninterpretable or if the patient is unable to exercise. That is the classical indication for cardiac CT, nothing else. And I think that's very important to mention, because not including everybody who wants to get the scan, which I did, I showed you just the case before, is actually not using radiation in the right way. There's one exception, certainly, and that is evaluation of suspected coronary anomalies, because that might be very difficult to do on MRI scans. So, one thing is important to mention. At some time, people believed detection of coronary artery calcifications is very important. And maybe you remember the big elephant, which we had also in Berlin, the electron beam tomography, aiming at only one thing, aiming at detecting coronary calcium. Well, that was actually pretty good, and these tables are still being used today, the Agassiz score, where we actually measure the calcium load and then make an estimate of the risk for the individual patient. And these numbers are based on a large population. It's kind of a very reliable issue. Well, then we realized calcium is only the tip of the iceberg. That's not the culprit lesion we are looking for. We are looking for some soft plaques, which later on may or may not develop calcifications. So seeing the calcium is nice, but actually we would like to catch the disease a lot earlier. So what we're looking at are soft plaques, which may not be calcified, but might rupture and then put emboli to the distal arteries. Well, as I said earlier, coronary angiography is the way to go as soon as you have the suspicion you might need to intervene and put a stent, for instance, into the artery. But there are some problems, and that is, it is a highly invasive procedure. And there are risks associated to that procedure. And there are some resources involved, and also certainly costs. And that is one of the reasons why there is decreasing acceptance in the population which actually can benefit from CT. Keep that in mind. We are only talking about people who have an intermediate pretest probability of disease, not the ones in which we know they're probably diseased. There is a sobering fact, I must say, and that is that the high contrast resolution over time in CT hasn't really been improved in the last 5 to 10 years. What has been improved is the temporal resolution. That's why cardiac CT is now coming, because we are able to freeze the motion, and actually the temporal resolution is meanwhile down to 80 milliseconds. Well, this is what happened if the temporal resolution is not good enough and scanning time is too long. You ask the patient to hold the breath, everything looks fine, and then suddenly after 20 seconds the patient can't hold the breath. Usually we are scanning patients and not individuals, which are healthy. So the patient couldn't hold the breath, and then the bottom part of this cardiac reconstruction actually cannot be interpreted. What we wish to have is a brisk, sharp presentation of all coronary arteries. Well, this is a graphical display of the current technology that's on the market. Different vendors have different strategies. One believes in very wide detectors. 2 vendors actually have some intermediate size of the detectors. And 1 vendor has a smaller detector, but, which is unique, has 2 of those. And I will show you why this is so beneficial. What I will talk about briefly is the KV and MAS adaptation. That's quite easy, because most of this has been mentioned already in the previous talk, and I don't think I can actually contribute to that discussion anymore. There's dose modulation, which we definitely need according to the cardiac phase. We'll briefly touch the topic of retrospective and prospective scanning modes, because that is the biggest implication onto dose in cardiac imaging. And we will touch upon briefly about 2 potential solutions to that problem, which would be either wide area detector CT versus dual source fast helical scanning. Well, irrespective of how big your detector is, as long as the detector is smaller than the area you would like to see, here's a bigger detector, you need a helical mode to cover the heart, right? And if you need 180 degrees for reconstruction, and you need to have time points in the spatial domain so that you can reconstruct at any spatial position during that acquisition, you need overlapping scanning. In fact, that's the leading cause for overradiation, because we have 4 to 6-fold oversampling on the acquisition side, and that consequently leads to 4 to 6-fold higher radiation dose in cardiac CT. Well, let me just show you what the beauty is on the other side of having retrospective gating. Because we can just walk through the cardiac phase and look, there's only one phase in which the coronary artery is sharp and in focus, so to speak. The other phases are of no use. You can actually say there's a huge waste of radiation. Once we don't look at these phases, why should we actually acquire them? Because we are not using them for anything. But if done right, if we select the right phase, we have perfect depiction of all the coronary arteries. But look at this. It's 12 seconds recording time. 12 seconds for such a short distance. It actually tells you how much over-radiation is being taken just to capture one single phase, which is then diagnostic. Well, let me repeat this, because I think that's very important to understand. The spiral technique with overlapping scanning is the leading course for the radiation in cardiac CT today. As I said, there are two solutions to that problem. All vendors actually worked on this. Number one is non-spiral scanning, be it having a detector that is wide enough to cover everything or having a detector that is too small and you have to fragment the acquisition into smaller pieces. Both work, both are very well in respect to lowering the dose. The other possibility would you speed up the helical scan so fast that actually only one phase is being acquired. Another possibility that works quite well. Once again, this is the helical mode in the conventional way in which we have over-radiation. But let me see what can happen when we have a detector which is as wide as the entire field we would like to see. Well, no helical mode is necessary, and subsequently no oversampling, subsequently a fraction of the dose. That's the key to lowering the dose in cardiac CT. There is a problem, I will tell you just in a second. Giving you an example, this is one of those very short acquisition time. In fact, it's single bead acquisition. You need only a fraction of the iodine contrast material. We have relatively low dose, and that's the resulting exposure to the patient. Well, if there wasn't temporal resolution, you need a full rotation to correct for the artifacts from cone beam. So people say, and the point is well taken, 175 milliseconds temporal exposure window, should I say, not temporal resolution, but exposure window is way too slow if the patient has a fast beating heart. And that's true. Well, the beauty is we can shift a little bit within the acquisition window, the reconstruction, but the problem will not be overcome. Exposure is a little bit too long and might result in blurry images. All vendors have a solution to this. What they simply do is they acquire more than one beat and just select the right acquisition parameters so that they can fraction the reconstruction built out of 3 different segments, for instance. Well, for each segment, the temporal resolution is way shorter, in the ideal situation 1/3, and you put them together and you have 180 degrees of data. Great means. But you as experts already realize what is the penalty for that? It is higher dose. It is 3 times the dose. You get better temporal resolution, but you pay for it. But sometimes it really does make a big difference. Look at this example. This is single beat. This is 2 beats, and there's a significant increase in detailed resolution, simply because we have been able to freeze the motion by acquiring 2 beats, and luckily they were at the same position. That's another risk that's being involved when you acquire more than 1 beat. Well, this is the slide I borrowed from Cynthia, and I'm very grateful for that. There is certainly other techniques, which is, why not acquiring a small fraction, move the table forward, acquire the next thing, just provided you don't have a scanner that covers the entire area. Same thing will result. We have very low dose. There's little overlap needed to make sure that there is no misregistration between the volumes, but the result is the same. It is not a single beat, but there is no helical over-scanning, and the dose is dramatically reduced. Same thing, just a little disadvantage because you need more beats. Well, the problem is you have only one shot. You can't make any changes retrospectively as to the phase you would like to acquire. That was the beauty in helical mode, because what you could do once you have the data, you can simply go back, and I showed this to you earlier, you can go back and reconstruct any phase within the cardiac cycle and get beautiful images. But usually, as I said, you don't need all of those. Well, here look again. The acquisition parameters is a pitch of 0.2. Now you understand, 5 times over radiation for phases you may or may not need. A potential solution is, well, you ramp down the MA. Only ramp it up at the time point when you think this is the phase you would like to acquire. And in different phases, you drastically reduce the MAS. Well, here is reconstruction from the phase you would like to get. Another reconstruction from the phase where you lowered the MA. Subsequently, the image noise is a little bit higher, but you may or may not use this image only for the purpose to see the valves, and you don't need much of radiation. A very simple means to reduce the dose in cardiac CT. Let's move on to solution number 2. Well, as I said, we need 180 degrees for reconstruction. So the temporal resolution is half the rotation speed, very simple. Here is the most brilliant idea within the last couple of years. Why not putting a second tube into the system? Well, I must say, let's not talk about the additional scattered radiation and effects on image quality. Just keep in mind, we only need now 90 degrees for rotation until we have 180 degrees of data for reconstruction. So in fact, the temporal resolution is halved, which is very nice for cardiac applications because it is in the range of 80 milliseconds. The only problem is we do not cover the entire area we would like to see. So we still need some spiral acquisition to be able to scan over the area. Potential solution is speed up the CT up to a pitch of 3. And what's going to happen is we have a single phase, high-pitch scanning, no way of changing the acquisition window, but we come down to the same low-dose technique as if we had a single-beat, full detector size CT. And here you see the pitch of 3.2, and we only have a reconstruction phase at a given time point, which we need to select beforehand. We can't change that. Let me show you the consequences. And I think this is kind of interesting because two directions are coming together to the same scanner. First thing is no table motion. Second solution was fast helical scanning. Well, here is the problem. As I said earlier, we have a temporal window which may or may not suffice for freezing the motion, but it is a single beat acquisition. On fast helical scanning, we have the same thing. The only difference is the in-plane temporal resolution is excellent, but you need still some time to scan over the heart, and that might be significantly longer than the in-plane resolution. Does it matter? Open question, but it is not at 80 milliseconds. So we have a little difference in the temporal domain between the X and Y axis temporal resolution and the Z axis resolution. That may or may not be a problem in certain patients. I think the only difference is when we have arrhythmia patients, then it plays a role. Let me show you why. There's a rhythmic rejection in most scanners built in. So if the CT detects, because this is planned prospectively, well, it doesn't work because there's an extra beat. It simply repeats the study. Since there's no table motion necessary, it just repeats the exposure. And usually, from the practical experience speaking, the next beat is actually even longer, compensatory. And in fact, the images look gorgeous. Sometimes images look better when the patient had an arrhythmia, right when we scanned the patient. Whereas when you have helical acquisition, you have to slow down the table very fast, either go back or repeat the study. So in those patients, single beat acquisition is of advantage over a helical mode. Let me show you an example. Here it happens, Murphy's Law. Just when we tried to acquire the data, there was an extrasystole, so the scan was repeated, and here's the data which amounted to 0.8 millisieverts for that scan. That's the safety you can have if there is no table motion built in. One thing I would like to mention to be complete, well, on the single beat acquisition, we still can use those modulation and then retrospectively change the window for reconstruction. As I said earlier, some phases will have low image quality because they're only obtained to see the valves. And here's an example. This is the full dose image at the time point when we wanted to have it. This is the low dose acquisition, and you see there's a different noise level on those images. And putting everything together, I would like to bring across, the key thing is, no matter what we do, first of all, we have to select the right patient group for scanning. That's the best means of reducing the dose. Second thing is we need to think about which parameter are we using to direct the CT, which parameter are optimal for imaging. Is that BMI? Is it APD chest diameter? Any sort of thing we think the physics of the patient is being best described. And then we need to define what are we looking for. Are we looking for occlusion of an artery? Are we looking for plaque composition? That question actually influences the dose quite significantly. When our question is, I would like to see, is an artery occluded or not? Then we can actually go for a very noisy image, and the standard deviation may be up to 67. Let me show you what that actually means. When we use that approach, and we select the right patients, right indication, right clinical question, you can see we narrow the area of exposure to the size of the heart, and we actually will result in, on average, 0.8 millisieverts per patient. Compare this number to numbers that have been published in the past using overlapping scanning using Helical Mode. It went up to 20, 30 millisieverts per patient. So that's the significant reduction in dose once cardiac CT is done right with the right indication, right selection of the patient, and right acquisition mode. Let me finish with a very sobering fact. And one of my colleagues actually analyzed from the literature, all multi-center trials, all randomized, what was the results of the study. Interesting. From electron beam tomography down to 64 slides, sensitivity was always above 80, 90%. It's even worse. Look at the negative predictive value. It's always above 90%. Question is that because people don't like to publish numbers below 90%? Could be a reason. Well, you have to look closely. What the reason actually is look what they did. 28% of the cardiac segments, of the coronary artery segments, were excluded from analysis, which means you perform some studies and then you think, oh, let's take away the 30% which we don't like, and then you make an analysis of the 70% best. Well, you can make a judgment if that is fair or not. But anyway, the negative predictive value used to be always high, and that actually is the reason why we think cardiac CT has its value for the right group of patients. But overall, the sensitivity can be regarded as above 90% for coronary artery disease, and the negative predictive value is way above 90%. There are a few things, and that's the beauty of CT. Development goes on and goes on, be it iodine maps, in conjunction to isotropic imaging, where we can change the plane where we want. This is one possibility. Or let's view the prospect of perfusion imaging, where we get perfusion maps. All this is possible, but keep in mind, the biggest thing here is we need to select the right patients and set the parameters right so that we don't over-radiate the patients. Now, in summary, I would still say standard helical cardiac CT is the significant source of radiation as described in my presentation. All dose reduction means, including dose modulation, changing kV, MAS, all things apply in cardiac CT as well. But I think the dramatic dose reduction comes through non-helical scaling, be it wide area detector CT or be it just fractioned like sequential CT, I don't care, but non-overlapping scanning is the best way to reduce the dose significantly. Or possibility number 2 is ultra-fast helical scanning using 2 tubes as described. But I would like to point out there are new clinical possibilities in terms of iodine maps and perfusion imaging, and we have to closely watch what the development will be in the future. Thank you very much.
Thank you very much, Patrick. We have time for a few questions. I noticed with the 1 tube rotation, you said the contrast media dose was about 35 mils. Do you still get the same max brightness? I guess I've always been taught a little bit that if you don't give enough, the concentration doesn't build up enough. Can you field that one?
Well, absolutely. That's true. I mean, having only, think about the exposure is 200 milliseconds. You only need contrast for those 200 milliseconds. So in fact, you don't need any plateau. You just need to make sure that at this little time point, there's enough contrast in the left ventricle. And that's a big challenge. So usually, since we don't really know, despite all the tricks of bolus tracking and everything we use, we cannot use all the time 35 milliliters in all patients. It is really difficult. But I just would like to point out the possibilities when scanning time is getting so short that we don't need a plateau for the contrast. We really need only one peak. That must be right, and at this time point we have to scan.
How fast do you have to inject?
We inject at an injection rate of 5 to 7 milliliters per second.
I was talking to our cardiology, radiology guy. He's not really a cardiologist, but he was pushing me to look at tube current modulation in our cardiac CT scans. And I was kind of reluctant because the cross-section doesn't change that much in the 12 centimeters or so that the heart exists in. But his point was that it would actually work on an AC mode. It would actually select a proper MA for a patient, even if it doesn't change very much during the scan. Do you use that kind of technology for your cardiac CT work?
It depends on which scanner type you're referring to. Are you talking about the helical acquisition or single beat full detector with acquisition? The reason why I'm asking is on full detector rotation, you can't use that technology. The only thing you can use is if the patient has oval shape, you can change a little bit the MA from the lateral view to the anterior view, but anything else, Z-axis modulation wouldn't exist, right? So when you have helical acquisition, my answer would be maybe it does change. That's going to be tricky with ECG gating and then modulation to frequencies. I don't know. I think that could be, maybe you can comment on that.
This is one of the sort of interesting quirks that you don't always get fully informed on, but on the Siemens product, for instance, called Kerdos 4D, and you are taught it modulates in X, Y, Z, and does this global adjustment for patient size. Well, in cardiac, because you need the projections at the right phase, and those are the ones you need, you can't risk having turned the tube current way down for those, so they can't do the XY simultaneous with the ECG gating. You could do Z, but I think they ended up turning that off. Wasn't buying much, as you thought. So even though you mark Kerdos 4D and you're used to thinking that does X, Y, and Z, in the cardiac mode, it really is just doing a global modulation. You know, bigger patient, I'll go up, but it's just one MA. Okay, well, thank you very much, Patrick. Sure.